Yeah, I think the conversations that we have with our patients approaching the decision for surgery are changing, particularly when it comes to patients who have clinical stage 2 disease or higher. The stage 1 patients is pretty straightforward still, I think, but those stage 2 patients and the stage 3 patients also, it's relatively straightforward, in that there's a rare patient that we're going to actually take to the operating room without having had induction therapy. Like similarly on the stage 1, no induction, have surgery, and then we can sort out the rest on the tail end of things. But it's those stage 2 patients, now there's a surprise stage 2 that you find out only postoperatively based on your path staging. But then those clinical stage 2 patients, what do you do with them, and how is it that you package the offer of surgery within the larger context of their lung cancer treatment plan that should nowadays include more than just surgery? So right now, we've got good data in the advanced stage space with patients who are otherwise considered unresectable. Again, it's not crystal clear to me how that determination of unresectability was made. Assuming that this is a technical unresectable patient, then it becomes really pretty clear. Again, if they're medically unresectable, that's something that is kind of somewhat immutable. But if they're technically unresectable, then the question is, are there some things that we can make them technically resectable? There aren't, to my knowledge, any people out there who do a lot of work in this space that are going to advocate straight away for taking patients who you're really concerned from a technical standpoint you're not going to be able to, operate on them, to give them induction therapy with the hopes of making them resectable. I think at best, we will hope that it might reduce the magnitude of the surgery required, such that if we're able to avoid a pneumonectomy, that would be huge, not just in terms of getting into a more favorable prognostic group, but to that patient's quality of life, of course, and to their ability to undergo ongoing chronic therapy, et cetera, associated with in the adjuvant setting. So I think that that's really pretty critical, but I don't think we're quite there yet, and I'm not sure how we're going to get there, if we're going to get there, when it comes to looking at a scan, saying this is completely unresectable, let's give some induction therapy and expect this to melt away and make for a much easier surgery. No one that I know of is hanging their hats on that.